Today I'm joined by Associate Professor Tom Ford, an interventional cardiologist originally from Scotland but now based right here on the Central Coast in Australia. Tom leads cardiology research and training at Gosford Hospital and holds academic roles with the University of Newcastle and the University of Glasgow. A passionate advocate for patient-centred care, he is dedicated to improving heart health outcomes across all stages of life. In this conversation, we dive deep into heart health with a focus on women, from the number one risk factor for developing a heart problem to unpacking high cholesterol, blood pressure, and what they mean for your cardiovascular health. Tom shares some red flags to watch out for, his top 3 lifestyle tips for a healthy heart, and why it's so important to make caring for your heart a priority during the perimenopause and beyond. Let's get into it. Tom, thank you so much for coming into the podcast today. I'm really honoured to have you here.
Thank you so much for having me.
I wanted to jump in straight away and say that if you ask most women what they're most scared of, it would seem breast cancer is the thing that women will say frightens them the most. And yet, when you look at the statistics, the reality is that heart disease is actually the number one killer of most women. Why do you think that women are not thinking heart disease?
I think that's a really pertinent point, and it's something that we see in daily practice. I think one of the things is perhaps there's a subconscious and a gender bias at play, and that's from women and men. Maybe we think that, it's the stereotype of the smoking middle-aged male that suffers, but the statistics, as you say, point out that women are actually the group whose outcomes have lagged men. So younger women specifically, something about that demographic where perhaps we overlook the diagnosis as doctors, and we know that the outcomes are not as good, or they've lagged behind the improvement in cardiac outcomes that we've seen in men. So I think it's a really important issue that we should address.
And whenever we think about, for example, a heart attack or a myocardial infarction, we think of those classic symptoms of, chest pain on the left side of the body, radiating down the arm. But in my experience, that's really how men often present with their heart attacks, so not always. But it does seem that women present maybe a little bit differently. Could you explain some of the ways that maybe a myocardial infarction or a heart attack might present in a female?
So I think, as you say, the dogma has been that women maybe present with less typical symptoms. There has been some researchers in cardiology from the States and other areas that have been looking to challenge that and say actually that women do present with more typical symptoms. Piecing that together for me as a clinician, what I see is that perhaps they do have the same symptoms, but they're much more articulate at describing them. And then because of that, it comes a whole interplay of additional symptoms that we maybe look at as being atypical, but perhaps they're all a reflection of the same thing. What I do in my daily practice for women who present with angina, I actually use a standardized questionnaire.
Right.
And I think by doing that, it maybe objectifies the symptoms and allows them the time and the space to kind of record. But the symptoms of a heart attack, for example, in a woman, chest pain, severe discomfort. Sometimes people say, it's not pain, doctor, it's just this feeling. But associated autonomic symptoms where they feel sick or sweaty and unwell. And I guess the message is if you've got risk factors, is to get medical attention. And typically, the clinical symptoms that you present with is one part of the puzzle, but I think we like to have objective tests, don't we, Shauna? So things like an ECG and a troponin blood test. And the combination of these things can be helpful in ruling in or ruling out a heart attack.
You mentioned angina. Could you explain to the listeners what's the difference between someone who's got angina and someone who's having a heart attack?
So angina is a clinical diagnosis for the syndrome of a heart muscle that's starved of oxygen. What it means is derived from Latin angere, to strangle. And so we typically have the syndrome where the muscle itself is unhappy because it doesn't have enough of its blood supply. And that is typically a stable phenomenon, meaning that there's many patients that are living with chest pain syndromes but don't have a heart attack. The flip side of that is patients that present with an acute blocked artery. And so they have a sudden change where they get constriction and they've got a clot in their artery superimposed on a fatty plaque. So hopefully that
Yeah.
gives an overview, isn't too medical.
No, that's great. And so what exactly is heart disease and why is it called the silent killer?
So heart disease takes many forms, and I guess cardiovascular disease in its general encompasses things like heart attack, stroke, or precursors to these syndromes, things like high blood pressure. It's a silent killer because we know pound for pound it's the most common cause statistically of Australian women's premature death and disability. So it's a really important thing. And I guess, like a lot of things, if we pick it up and treat it early, we can prevent really serious adverse outcomes.
And so you mentioned blood pressure, and obviously people are very used to going to the GP and having a blood pressure cuff put on their arm. Why are we so obsessed with blood pressure, and what does it actually even mean?
I'll give you my opinion as an interventional cardiologist. It's probably quite a simple take on it, but essentially the blood pressure is the pressure exerted on the blood vessel wall within the artery. And it is an independent risk factor, meaning that it drives events like heart attack and strokes if it's left unchecked for a long period of time. So from a patient's perspective, someone that's seeing me with resistant high blood pressure, what that means is we have a treatable opportunity to help them live the best life, statistically speaking, and reduce the risk of an event like a stroke or a heart attack that might jeopardize a fun and relaxing retirement with their other half. So it's a really important thing to pick up on.
And so what would be a good blood pressure?
So typically, target blood pressure would vary depending on who you're treating. But a figure for your audience, if they're in middle age, perhaps around the time of menopause, 120 to 130 systolic and 70 to 80 for diastolic. And people often say to me, "Oh, doctor, have a look at this blood pressure diary." They diligently complete their blood pressure diary. And, they're very concerned that they've got, one or two episodes of blood pressures 160 and blood pressures of 90. And to me as a specialist and to you, I'm sure we would see that and say, actually, that's okay, because the natural history of blood pressure, like every organ system in the body, is cyclical. And therefore, we know that with pain, blood pressure go up. I had a patient this morning, I was having a heart attack and I was ballooning his artery, and his blood pressure at the beginning was 100. And then during the case, he's uncomfortable in the chest. The blood pressure goes to 170. And then at the end, he's feeling relaxed. The artery's open. We've given some medications. It's 80. So I think the take-home message for your listeners is the blood pressure will vary. And it's more about the average long-term target. And so if it's persistently, those numbers are, 100 for the bottom number, the diastolic, and, 150 to 160 persistently, it's not an emergency, but it's something that needs treatment. And if it's confirmed in more than one setting, and we've tried diet and lifestyle changes, that generally that should be treated with medication.
What about the person who comes into the GP and they get very uptight and they know that their blood pressure is always very good when they check it at home, or they use their mum and dad's blood pressure monitor and it's all okay, but every time they come into the GP, they seem to get really uptight about their blood pressure. What's going on there?
It's a difficult one, isn't it? So-called white coat hypertension, and it is very common. And the way to manage that, and I'm sure you see that commonly in your practice as well, is to get them to do a home blood pressure diary. So, and actually knowing your numbers is a key message for your listeners, isn't it? It's empowering to know what is your normal blood pressure, and actually taking ownership of your health is very important. And so, $100 for an Omron on Amazon, that's the brand of blood pressure machine. You can have a blood pressure machine that's very accurate, and bringing the readings in, I'm sure, would impress you as a GP, wouldn't it?
Oh, my patients are very good. They
yeah.
bring their little notebooks in, and of course now,
That's so helpful.
yeah, it is. And what about I have a lot of patients who have an Apple Watch or a
Yeah.
smartwatch, and they will sometimes become a little bit fixated about their heart rate and get a bit worried about their heart rate. Do you have any idea, one, how accurate those things are, and also when do people need to worry about a too high heart rate or a too low heart rate?
Yeah, that's a great question. And I believe that they are very accurate. I think that the governance process to get them approved by the FDA in the States means that they are going to be quite accurate. We often get these patients that are understandably worried, saying, "But doctor, my heart rate's 35 overnight." And my response is like, I wouldn't worry about it. If they don't have any symptoms, then nocturnal bradycardia, where your heart rate drops overnight, can be quite a normal phenomenon. In terms of the higher heart rate episodes, I like to use the standard adage of 220 minus the patient's age, of how far they can kind of push their maximum heart rate during exercise. But, if their heart rate is high, it all depends on how they feel as well. If your heart rate is 180 and you feel okay, that's probably okay.
Yeah.
And that doesn't worry me per se.
Okay. So I see a lot of women
Mm.
struggling with perimenopause, and I definitely see a significant number who complain of palpitations. And I have to admit, over the years, I've probably sent lots of them to yourself and other cardiologists,
Yeah.
being very worried. And then I began to realize, oh, hey, there's a bit of a theme here. And a lot of these women will respond quite well to some hormone replacement therapy. And it is like those palpitations go away. Do we know what the mechanism is for that? Do we have any ideas?
I'm interested to hear more and look at the research into that, but I don't think we've got a mechanistic explanation. But certainly it makes perfect sense, doesn't it, that the hormone changes have key roles in terms of the biochemistry, thinking about things like endothelial function. And my own personal interest in the subject to my PhD was on angina syndromes, particularly focused on people who don't have blocked arteries. And one of the big groups that we see well represented in this is women, and specifically women who've either had an early menopause and a long time of maybe relative estrogen deficiency, but also in patients that have developed, around the time of menopause, some angina type syndrome. So in answer to your question, I think more work is needed, but perhaps this is a group of patients that might be overlooked but might benefit from treatment.
Yeah. And the other thing that I see a lot in my perimenopausal women are people who've always had a good cholesterol,
Mm,
and they've always like, oh, my cholesterol's always been, 4 or 4.2. And then suddenly they've got this cholesterol that's suddenly 6 or 7. And they're like, doctor, I haven't done anything different. I'm eating the same, but I'm probably putting on weight, but I'm, gaining weight, but I'm still exercising. And I just don't understand why my cholesterol has gone up so much. Is that a phenomenon that you've seen with your patients as well?
Look, I think I'm here to learn from you as well, Shauna, and I think that that kind of serial assessment for patients that might be low risk are not the type of group that I see. They're not repeat offenders at my practice, which is one of these facts that just reflects the kind of population that I see. But certainly, I think that there's clearly mileage in that, isn't there? We definitely see weight gain would be the one thing that we see routinely, because what goes hand in hand with weight gain is high blood pressure, an increased risk of AF, which is would cause palpitations. And so certainly that's definitely something I've seen a lot of. And I think there's a kind of dogma, isn't there? Because we're all really worried about doing harm. But we've really got to think about doing benefit as well, isn't it? And I had a telehealth consultation with a GP today, really, really well-respected, fantastic GP who we had this really important shared decision-making about the risk and benefit of blood thinners. And actually, this is a very similar discussion. If you've got, high blood pressure and a family history, and we're all a bit worried about you having a heart attack or stroke, but you've got severe symptoms of menopause, and clearly you've got blood test arrangements that go with that, how do we approach the subject of treatment? And in my mind, perhaps we're under-treating that group of patients.
I agree. And I think, that shared decision making is so helpful, but it's really a challenge and it's so nuanced. I know whenever people are often listening or they're, following people on social media, patients will often sort of type little questions in, well, can I do this or what
Yeah.
can I do that? And you just can't
Nuanced,
answer
isn't it?
you
Yeah.
can't answer
Yeah.
those questions because it's so nuanced.
Yeah.
But another group that are definitely coming to see me are, so it's that cohort of women who've really missed out on HRT because, let's face it, for years we really didn't prescribe it. We were all a bit scared to prescribe it. And, there is a group of women right now who are in their 60s and 70s who are kind of coming back and going, hello, I'm still over here with
Wow.
my hot flushes and feeling terrible. Oh, I'm over here, but I would like the protective benefits of hormones for my
Yeah.
bones or for my heart. And I have to say that's one that I'm trying to navigate my way through because I'm definitely attracting some of those older patients who are really keen to have HRT, but where I'm getting a little bit stuck is some of the data, of course, talks about starting hormones within 10 years of
Yeah.
menopause. So I saw someone today who was at 11 years, and I'm thinking, okay, well, what are we going to do here? And she's definitely very symptomatic still, unfortunately, not sleeping, terrible hot flushes.
Yeah.
But I find myself going down this route of thinking of, do I need to have a coronary calcium score? Do I need to rule out pre-existing heart disease before, I embark
Yeah.
upon hormones?
Very
And
difficult, isn't
it's
it?
very difficult, and it's so nuanced and personal, and there doesn't seem to be any very clear guidance.
No,
I
there's
feel like
not.
we're fumbling our way along.
There's probably room for some clinical trials, isn't there? Some randomized data. But for me, I'm increasingly relaxed, I think, because I'm really valuing quality of life, right?
Ah.
So we just want to be not just living longer, we want to be living better, right? And for me, if I just read, not being a female, but, irritability, mood, sleep disturbance, libido drops off, the weight gain, it's like, that doesn't sound really fun. And it would be really difficult. And I would generally lean towards, a better quality of life, even if it meant taking some risks. And that maybe is a reflection of the doctor that I am, dealing with a lot of acute patients. And, I do 1 or 2 days a week in rooms, but mostly I'm doing heart attacks and seeing people that have really had dramatic events. So, whilst these are really important discussions, I think most people who go into HRT are not going to have heart attacks and strokes. And if we can get 5 to 10 years of really better quality of life, I think most people would be happy to take those risks.
I agree. And I think, if you're sitting in reality, that every night you can't go to sleep, or you're up half the night with hot flushes, or, you're feeling anxious or whatever, and that's your actual reality
Yeah.
versus a theoretical risk.
Yeah.
I think it is very hard whenever a lot of women are coming up against a brick wall
Yeah.
and being told, oh, well, you're too old.
Yeah.
And you're kind of like, oh, right, so I just have to continue to be over here being miserable.
I don't think that's a good. I think seeing a specialist like you who has expertise and looking at the kind of risk and benefit, and some of these women probably will go into treatment and not have a great response, and then we can maybe look at the risk and benefit and say it's not there.
Yeah.
But I'm sure a substantial majority will actually say, actually, this is great. I feel a lot better. And I think for me, the research is needing to be done, and on that group maybe in later life or maybe beyond 10 years. Just because they've got some hardening of the arteries, doesn't mean they can't go on it. In my view, probably no. But if they've had a previous event, obviously that's a different risk group. So primary prevention, we know that there's probably a prothrombotic component to HRT, and maybe, I don't know, with transdermal estrogen, is that maybe a little bit lower risk?
Yeah, it seems to be.
Yeah.
It actually seems to be substantially lower. So I have
That's
to say,
good
we've
option.
all really, I can't even think of the last time I've given anyone oral estrogen in terms of HRT. It's all gels.
Where do they have the
patches.
patch? And
Yeah, so that's another story. So there's a worldwide shortage of patches, and
Okay.
Australia, clearly we're kind of at the bottom of the
Oh,
pile,
yeah,
and
yeah.
quite literally the bottom of the world. So at the minute, I say most of us are using gel.
Okay, yeah.
Because there's a supplier and manufacturer based in Australia. So yeah, we're using a lot of transdermal estrogen. But just on the note of maybe I could use you to help explain to listeners, how do women know, or anyone listening know, where they are at with their heart health, and when, because we are very privileged here in Australia that we can access. Certainly love being a GP here because I can do lots of
It's
investigating,
amazing.
and it's
The access
so
to healthcare testing is incredible.
it's amazing, and it's so much more interesting. As you know, and you worked in the UK as well, it's
Yeah.
very frustrating as a GP there because you have to
Just
keep
refer
referring
everyone.
everything to the hospital, and it's so frustrating.
Yeah.
So I do love it. That's great. But when does someone perhaps have like an exercise stress test, where people will recognize that as they walk on a treadmill attached to an ECG? And when should someone have an angiogram, or when should someone have a CT calcium score? So do you mind if we chat about those
Sure.
investigations and who they might be appropriate for and what they're telling us?
Sure, no problem. So maybe we could deal with them in turn. So
Yeah.
the stress test, which really these days should be a stress echo. In my mind, that's a really helpful test. It's very safe. It gives us really free information on exercise capacity. And not just blocked arteries, we sometimes see arrhythmia. So patients may have, propensity to AF, where the heart goes out of rhythm, and that can be brought on with a treadmill test. So in my mind, that's particularly helpful for women with symptoms. Okay. As a screening test, perhaps it's less useful, although it's still pretty safe, and there's no ionizing radiation. So that's a specific consideration for a female population with radiosensitive breast tissue. We're talking about things like CT scans that all have radiation. So stress echo, very good in terms of safety. It's pretty low risk to the patient, and it gives us information on symptoms, particularly during exercise. One of the more accurate ways of detecting plaque, which is particularly helpful for determining future risk, is the CT scan. So a CT scan is where you go through typically a donut-shaped pipe. People that are claustrophobic, still it's pretty reasonable to have it. It takes about 2 minutes. The first half of that scan is called a calcium score, and that simply looks at calcium in the distribution of your heart arteries. And that's scored relative to your age and sex. For your female listeners, especially if they're kind of young or in young to middle age, I think we can sometimes be falsely reassured by a low calcium score.
Right.
And so if you were to tell me, look, I've got a lady, Tom, would you mind seeing her? She's 45, but her dad had a heart attack when he was 40. CT calcium score is 0. I'm not reassured by that at all.
Okay, this is really
Yeah.
helpful.
So I think in that patient group who's asymptomatic, who has a very strong family history, we've got to be really careful, because that's the one thing. The genetics are such a robust predictor of outcome, long-term outcomes I'm talking about. And a lot of our patients, they do want to be told, look, it's empowering to think that everything's in our hands. If we live clean, do yoga, and eat well, we'll be fine. And I would say, yeah, we'll be protected to a certain extent, but maybe that we're delaying the onset for the inevitable, maybe by 20 years. And that's not being defeatist. It's just to say the reality of genetic determinants are really strong. And we're talking about really strong family histories here. If your mum and dad were in their, 80s, that's pretty reasonable, isn't it? But if they were young in their 40s or 50s, having bypass and stents.
So I'm just going to pause you there a minute just to make sure I completely understand, and everyone listening. So if you're young and you've got a very strong family history of heart disease, and you have a CT calcium score and it comes back as 0,
Yeah.
you would not be completely reassured by that. Can you tell me why?
Yeah. So it's simply to do with the phase of the plaque buildup. So imagine we've got a circular tube, which is your heart artery. And inside that artery, the first layer is where the plaque starts to develop. That's the endothelium. Think of it like a Teflon coating. And so when we're young, that's not going to be hard or calcified. But typically that layer will thicken and develop with plaque, which is deposit of cholesterol and atheroma inside the vessel. And that is not calcified. So for younger patients, typically, they often have non-calcified plaques, and we can see them on CT scans, but we can't see them until we put in contrast. The point that we're making is, if you've got a strong family history, even if the calcium score is 0, we've still got to be really careful. It doesn't mean that we're in a terrible situation. It just means that we need to continually reassess risk. We need to know what your blood pressure is. We need to know what your LDL is. And we need to maybe follow that patient up. It doesn't need to be with a specialist. It can be with a GP that's concerned and interested. But the more accurate way for detecting soft plaque is not with calcium, because it's non-calcified. It's with contrast. So the analogy of looking through the pipe, we can put contrast through the pipe. That's either invasive. That's the invasive coronary angiogram. But I think for most people who don't have symptoms, we wouldn't recommend an invasive test. But the CT scan is where we can actually inject contrast through the vein and wait for roughly 60 seconds until it's in the heart arteries and take a picture. And we can see quite clearly, normal vessel, if there's a mild narrowing with soft plaque, we can see it as well. And that's probably even more important in determining risk than calcium.
Right, okay. When do we do cardiac stents now versus angioplasty?
The typical role for coronary intervention is for people who've had a heart attack. That's the strongest intervention, strongest evidence base. So if you've had a heart attack and you've got a single vessel blockage, a good treatment is a stent. And what that means is typically these days going in from the wrist into the heart. and performing a balloon dilation and keeping the artery open with a stent. And in my mind, these days, that should then be accompanied by an assessment of the adequacy of the stent using either an ultrasound or a light catheter to make sure that the stent's well expanded.
Right, okay.
And so that group of patients is pretty clear. I guess for a lot of patients that we see as outpatients, they have symptoms. And I think for most patients with stable coronary disease, we would like to see that they would have some type of symptoms or vulnerable soft plaque in an important area that was detected on CT. And I guess these types of decisions should be personalized. And if patients don't have classic symptoms and they don't have severe disease, then it's reasonable to treat blockages with medication.
And in terms of cholesterol, can you explain to the listener, lots of people have heard of good cholesterol,
Yeah.
and they've heard of bad cholesterol, and then they've heard of triglycerides. Can you explain a little bit about that and what they mean?
Sure. So LDL is the low-density lipoprotein, which is a subform of cholesterol that's particularly notorious for being implicated in the development of blocked arteries that cause heart attack and stroke. And so we've done studies over many decades, close to 4 decades, of the most commonly used drugs called a statin. And whilst these historically have had some bad press, and the medical data is pretty overwhelming, actually. These are really cheap drugs, cost a few dollars, and they can be potentially life-saving for a huge number of patients. The LDL is particularly bad at causing influx into plaques, and it's something that then drives inflammation inside the vessel wall. And inflammation can cause a plaque to rupture, and the rupture of a plaque is what causes a heart attack.
So our LDL is the bad cholesterol.
Correct.
And do we have a number that we want that to be or a number that we don't want it to be?
Yeah. So I guess a listener that doesn't have a strong family history, that has normal blood pressure, we would be quite relaxed about having cholesterol that's just a little bit high. So we're talking about maybe cholesterols of 5.5, 6, 6.5. With LDLs of 3, I would be relaxed about that. If there's no strong family history, the patient doesn't have diabetes, blood pressure is normal, and for an older patient, if the calcium score is low, that's an additional reassuring feature. We also like to see the breakdown of the good cholesterol, and you mentioned that as being the HDL. So HDL is good because it takes the circulating cholesterol out of the bloodstream. And typically, we would like to see the HDL 1.5 or higher. And we know that HDL is correlated with a good diet and exercise and the things that we know are good for your heart health.
On Sunday morning, when I was out walking at Terrigal Beach, which is a local beach, I kept crossing paths with a number of women who all had vests on, just like me, weighted vests. And we all gave each other a bit of a knowing look because these have become very, very popular in peri and postmenopausal women. You might not know what rucking is, but basically what it is walking with either a weighted vest or a weighted rucksack. I personally opt for the weighted vest because I find it very, very comfortable and very, very quick to put on. So for peri and postmenopausal women, there are definitely a number of health benefits that you can gain from walking with extra weight. One of the health concerns that many women have at this stage of life is developing heart disease. And unfortunately, we know in the postmenopause, the rates of heart disease for women really start to accelerate. So why might rucking or walking with weight change that? Well, basically, whenever you're walking with additional weight, it increases your heart rate more, and it basically makes your heart exercise a little bit harder. So hopefully making your heart a lot more healthy. So that's one of the benefits of rucking in comparison to standard walking. So if you're intrigued and ready to start rucking, my recommendation would be that you start low and go slow. So start by choosing a weight that is 5 to 10% of your body weight at maximum, and take it slowly. Go for maybe a 10 to 20 minute walk at first. Don't decide to go on a 5-hour hike the first time you strap on your weighted vest. So we've been chatting to our friends at Rucksack, and I've got a special discount code for you. So if you go to their website, which is www.rucksack.com, so RUKSAK.com, and use the code Shauna15, So that's SHAUNA 15, you're going to get a 15% discount. So whether you decide to go for a vest or whether you decide to go for one of their backpacks, either way, you're going to get 15% off. Now, let's get back into the episode. If you could give people some tips of things that they could easily change in their lifestyle that will make a big difference to their heart health, what would they be?
The lifestyle factors is movement, right? It's trying to find an activity that we know, and this is not just for the risk of heart attacks, but it's to continue aging well, right? It treats a lot of things. So a regular form of physical exercise that has to be sustainable, whether that means doing it with friends or perhaps some social connection with that exercise, I think that would be a really good thing. And then in terms of the diet, I think sometimes we see people go overboard, don't we? And we can take the diet kind of too seriously. But my feeling is that diet is very important, but up until a point, and we've got to have the right balance, right? And so red meat, for example, in my diet, I would have red meat probably 2 to 3 times a week, and I don't feel guilty when I have that. I enjoy it, but I think to balance that out, I like to have a lot of vegetables and high fiber vegetables, green leafy vegetables, and liberal use of kind of good fats. Things like legumes and olive oil, avocados. So that type of thing will boost the HDL and I think give you a bit of balance. The other thing that maybe not many of us eat enough of is oily fish. So 2 to 3 times a week. Salmon's quite heavy, isn't it? But we live in a country with amazing seafood. So barramundi and fish, I think, should be a regular feature on our dinner plates.
In terms of supplements for the heart, are there any sort of vitamins or minerals that people seem to be deficient in that seem to play a part in heart health?
No, I would say in general terms, if we've got a good diet, there shouldn't be too much need to supplement it. We do see that there's a lot of patients that take supplements, and if they feel better for taking it, I'm happy for that to continue. My own feeling is perhaps they might be overused, and I've seen some patients recently that have actually come into a bit of trouble from too many supplements, including some kind of elite level athletes and things like that had toxicity from different vitamins. But the things that would be maybe under used, perhaps vitamin D would be a good example of one that, as Australians, the sun's so strong, my skin's taking a beating out here, but vitamin D is probably a good thing to replace. Something that we would often stop is calcium supplements, because we do think that if you've got a normal non-vegan diet, you get enough calcium, and it can be detrimental in terms of building up into plaques and causing hardening of arteries.
So that's definitely a tricky one, because I definitely see patients who've perhaps seen dietitian or nutritionist and there's concerns around their bones and maybe having a bit of osteopenia, and they're being told to take calcium supplements, but yet they maybe already have quite a dairy-rich diet. And so you're saying that calcium actually could be a bad supplement to be taking?
Well, we know from good data, looking at, hundreds of thousands of patients, that at a population level, we probably will be doing harm by prescribing, blanket amounts of calcium supplements. But it comes back to the concept of the absolute risk to an individual. The absolute risk is probably quite small, but if we treat enough patients, then that's an important concept to think about. So for me, I'm quite relaxed about stopping the calcium supplements, because I don't think there's a robust, correct me if I'm wrong, I don't think there's a robust data to say, if you take the calcium supplement, you'll have stronger bones and you'll have less osteoporotic fractures. I think, if anything, it's just us wanting to try to be doing something.
Yeah, it's to do something.
Yeah. Yeah.
And obviously smoking has gone out of fashion a lot, but there's definitely still smokers around.
Yeah.
What is it that smoking does to your heart?
So smoking has a number of toxic substances, predominantly that inflame the vessel wall. So we see, if we measure C-reactive protein, which is a bloodstream marker of inflammation, that's definitely higher in smokers. And the first thing that happens is the endothelium, which is that Teflon coating inside the blood vessels, becomes angry and it becomes permeable. So by permeable, we mean that it becomes a bit like a sieve. So the LDL, the cholesterol particles, can diffuse through the lining of the vessel walls. and can build up in plaques, and that's what we see in smokers. And yeah, I would say that definitely that would be a very important thing to address. And perhaps vaping, of course, it's definitely common.
Oh, it's unbelievable, isn't it?
And
I just cannot believe how many people vape.
and
It's
it probably does some similar things, but probably not quite as bad for you as tobacco.
yeah. So if you had a patient who you'd seen and they'd had a myocardial infarction or a heart attack, you would be strongly encouraging them to stop vaping like you would have been doing years ago when people were smoking.
Definitely, yeah.
Yeah.
I think it's important to keep people on side, though. You got to kind of understand it from the patient's perspective as well, right? These things are very addictive. I kind of understand addiction quite well. And my own dad, he is a reformed smoker, but still uses nicotine gum. So I still, I understand that from the patient perspective. It's not easy. And I think you have to have sometimes a negotiation of what's the priority for that individual at any one moment in time.
Alcohol and the heart. Talk
Yeah.
to me about that.
So alcohol definitely can have risks for heart health. Specific risks would be high blood pressure and an increased risk of arrhythmia. So those would be the two big ones. The arrhythmias that we commonly see in people who use too much alcohol is AF and ectopic beats. But in terms of the arteries, some of your listeners will be pleased to know it's actually not a potent risk factor for blocked artery heart disease. In fact, there's kind of a sort of running joke in a lot of cath labs that in alcoholics' hearts, you just often see these big clear pipes. I don't know the alcohol, but it definitely has hazards for heart, and I think they are well recognized. It can cause a weakening of the heart muscle as well as arrhythmia. But I think, like a lot of things, we've got to have balance, and I'll enjoy a few drinks at the weekend. Just trying to have a few alcohol-free nights a week would be a good approach.
What about like 10 or 15 years ago, or maybe even longer, it became very fashionable for people to drink red wine, and they would tell you that it was for the heart. I did read somewhere recently that apparently the wine industry were very prominent in pushing that narrative
Yeah.
as well. I do have patients who, drink a bottle of red wine every night, and they
Yeah.
tell me it's for their heart. What do you think about that?
Yeah, it sounds like my dad you're describing. But look, I think probably the data is not very strong. So like we try to practice evidence-based practice. And if you just think about the typical person that's drinking red wine, they're people who are probably going to doctor's appointments. They might have a better balanced diet and they might be a bit more affluent. And therefore, the studies might show that they've got a better outcome in terms of reduced risk of heart disease, but it's because of confounding variables. And it's very difficult to adjust for that. So a short answer is probably, a little bit of alcohol, doesn't really matter what type, is okay. But beyond 2 to 3, maximum of 2 to 3 standard drinks per one session, and trying to have a few days off a week would be a good tip from me.
Amazing. In terms of, I've had a couple of patients recently, who've had myocardial infarctions, and they have been quite depressed after that episode. I think quite scared, quite nervous about doing things like they know they need to do exercise, but they're quite frightened in case they have another heart attack. And also quite frightened about having an intimate relationship with their partner. Again, very scared, or the partner being very scared. I wonder, could we talk a little bit about that sort of emotional impact of heart disease?
That's huge. It's absolutely massive, isn't it? I think probably it's the most common comorbidity after heart attack. So it's the most common kind of adverse outcome is anxiety and depression. And it's not just for women, right? It's for men, and perhaps women have an advantage that they're naturally often more able to talk about it. And so for my patients, I try and just kind of preempt that and just say, look, it would be almost unheard of for you not to feel real dark days in the months ahead. And there'll be a lot of soul searching after this type of an event. And one of the things that we know through clinical studies improves outcomes is cardiac rehab. And it's run by amazing nurses that live on the Central Coast and do an amazing job. And that really is shown to improve outcomes. And a lot of it is driven by fear, alleviating fear and anxiety. And that actually is important for lots of medical problems, isn't it? It's actually when patients understand what is going on here, it allows you to kind of come to terms with it. And actually, a lot of symptoms will reduce. We know that one of the big predictors for bad symptoms is anxiety and depression. So I think if we can address that head on, it's very important.
And can patients safely have sex after they've had a heart attack?
They can do. I think the guidelines to have a couple of weeks off. These days, we typically have complete revascularization. And what that means in plain English is if you've had a heart attack, you've typically either had 1 or 2 blocked arteries or sometimes 3. But we would try and replumb everything so that the patient has no significant residual blockages. And provided they don't have a severely weak heart muscle, I think getting back to these type of activities that give us joy and bring us closer to our loved ones is really important.
In terms of erectile dysfunction
Mm,
being a sort of canary in the coal mine for potential coronary artery disease, I remember being taught that at medical school.
yeah.
Would you say that that still stands as that if someone has ED, that it's worth them having coronary investigations?
Yeah, it's a difficult one, isn't it? Because I think it is a risk factor or an association, right? But there are obviously other factors that could be at play. And I think for most men as we get older, erections can be a challenge, right? And I think we've got to support men living their best life, which means having access to erectile dysfunction medication. One of the theoretical risks is if you've got, critical blocked arteries or a significant weak heart. And I think if there's a question mark about those, especially symptoms to go with it, we would often do testing. Probably the basics are more important, which is to make sure that that patient has adequately controlled risk factors. So LDL under control, we would often see a history of diabetes and comorbidities, like cholesterol problems and blood pressure problems. And I think really it should just flag up that maybe that patient would benefit from medication and further testing. If the patient wasn't too keen to go on tablets, maybe a cardiac CT or a calcium score would be helpful. Because if the calcium score's, 500 and, in the top 10% for their age and sex, it helps to refocus that conversation with the patient. Like, actually, this is something that's probably going to need medication to treat.
Another question that I was asked to ask you was about cocaine and the heart and so-called cocaine heart attacks.
Yeah.
Can you talk to me a little bit about that?
Sure. Yeah. Well, working in Sydney's eastern suburbs for the best part of 5 or 6 years, we would see a myriad of ways, I would say, that cocaine can affect the heart. So it's well-known vasoconstrictor, so it constricts blood vessels, and it's possible to have a heart attack with cocaine without blocked arteries. And we sometimes see patients develop weakening of the heart from cocaine. But in addition to that, if you've got pre-existing plaque, so you've got a 60% blockage, you don't know it, and then you've got an intense surge of blood pressure and constriction, then it can cause plaque rupture as well. So it can cause lots of different things, and we've seen lots of patients, including young men and women, that presented in different ways with it.
Are there any other drugs that you think are problematic for the heart?
That's a good question. So working on the Central Coast, I don't see a huge amount of problematic drug use. I think the one group maybe that we've not talked about would be kind of stimulant drugs, and the big one would be kind of ice or crystal methamphetamine. I think it's more of a common in different pockets, but we would definitely see, regular use of that can provoke cardiomyopathy where the heart becomes weak, all the associated problems with that.
Are there any other heart conditions that you think that are a problem for women or men that you would like to get sort of more information out there about?
Yeah, so I think one of the messages I would like to give to your women listeners is, trusting their intuition. And I always say to anyone with a medical problem, if you don't feel happy and you've kind of been fobbed off or told it's nothing, it's okay to have a second opinion. And that's fine. Like most doctors and me and you, I would be really happy for my patients to have a second opinion. We're all busy and we're lucky to be busy, right? But you've only got one life. And if you don't really get on or fully trust or really feel the same way as your doctor, it's definitely worth having a second opinion. Even if the conclusion's the same, it would be therapeutic. So that would be a good message for everyone to take away. The other things would be about specific syndromes in women that can cause heart attacks. So we see sometimes bruising inside heart arteries, and it's just more an awareness that women have perhaps different types of heart attacks than men. And we're starting to do research in Gosford and elsewhere in Australia looking at different disorders. Spontaneous coronary dissection is one of them. And the other one relates to patients, often postmenopausal females, who have angina, but no blockages in their arteries. And that is really interesting to me. That was the subject of my PhD, and we're doing that routinely. We can actually test to diagnose why do these women have angina, and we do believe it's related often to small vessel disease in the heart, which is the microcirculation. And why is that important for women? They need to know, well, actually, a CT is not going to show that. CT only looks at the big vessels, so they could be missed. And the other group is women that have propensity to spasm. And
My mum has that.
So vasospastic angina or microvascular spasm, and that's definitely more common, perhaps with hormone changes with age, and it's probably underdiagnosed, and it is potentially treatable as well.
So what is that treated with hormones then, or way do you treat that?
There has been studies done, and I think they're kind of conflicting, but I think if there's another indication for the patient to go on HRT with lots of hot flushes, then I would definitely support it, because I think anecdotally I've seen patients feel better on it. But typically we would give them a vasodilating medication like a calcium blocker, and we often use that to treat high blood pressure. The challenge is that not all these women have high blood pressure, and all of these drugs are relatively dirty, for want of a better word. They're not targeted on the heart, so they often have off-target side effects. And some of the time they're worse than the symptom.
Yeah.
So mostly my patients like an explanation, and then we have a shared discussion about treating that and reducing their symptom burden.
And is that spasm potentially something that could give you a full-on heart attack?
Yeah, we definitely see a higher incidence of heart attack. I guess not all heart attacks are created equal, and the type of heart attack that we see with the common form of spasm is typically relatively small events that may not change their life, which is a good thing, but still really impact quality of life and lead to real, impairment of function and going into hospital and, prolonged hospital stays, etc. So it can be a really important thing to try and prevent for patients.
I promise I'm getting to near the end.
You're doing great. Yeah, I'm having a good discussion. And
Heart failure. What is heart failure? Because it sounds very, very scary.
so heart failure is the clinical syndrome where the heart is not able to pump and keep up with the body's needs. And it's typically associated with either normal heart function, and that's more frequently related to a stiff heart, often in older women, whereas the other form of heart failure relates to a significantly weak heart. And worldwide, the most common cause of a weak heart is coronary blockages, but there are other causes as well, and genetic weakening of the heart muscles is very common as well.
If you have heart failure, is that ever reversible?
So I would say, like a lot of things, it's treatable but not curable. And to have heart failure, typically it means that there's established structural changes within the heart that will always be there. But certainly those changes are not always indelible and they're not always fixed. So examples of that are pertinent to women would be stress cardiomyopathy, or the called broken heart syndrome. And that's typically thought to relate to changes in hormones and microvascular dysfunction. And what happens is that the heart can become severely weak after an emotional or physical stressful event. And it's much, much more common in women. In fact, it's the more common cause of heart attack in postmenopausal females. So
you literally read my mind. I was going to ask you about broken heart syndrome because I had a patient who recently died within 2 days of her son dying.
Yeah.
And
would have been.
It seemed to have been from.
Yeah.
I wondered, was it broken heart syndrome?
You're right. I think without doing an autopsy, we wouldn't know if she'd had a plaque rupture, but certainly it's not all the way benign. And by benign, we meaning, we think of it as something that always gets better, but actually the outcomes, and we've seen cases really in Gosford of really severe heart attack with this, are actually similar to a blocked artery heart attack. The outcomes from the INTERTAC registry, which is one of the big contemporary trials of this, that the clinical outcomes are similar to blocked artery heart disease. So it's very important. And we still don't have a great understanding of the mechanisms and also the treatment. So there's a lot of things that we're still trying to get better at.
We seem to live in a very stressed world at the minute. Everyone seems to be busy and everyone seems to be stressed whenever you talk to them. And I know that I'm guilty of that.
Yeah.
do we actually have any firm data around stress and its impact on your heart health?
Not as granular and firm as what we would like, but I think anecdotally we see it is a big risk factor for coronary vascular events, and it doesn't help conditions like high blood pressure. And I think probably more work's needed, but there's not a great test for stress, and I guess it's increasingly prevalent in all of our lives, and so I guess for us as doctors, we should learn from our patients, right? So we're seeing people's lives literally every day change and take a different course. And what it's taught me as a kind of middle-aged dad is, really cherishing and spending the time leaning into the things that really matter. And part of that means, trying not to work too hard, and trying to take the time to balance, and that helps to manage what is a very stressful job, right?
Yeah.
I don't know how you manage that, but you've obviously done well with.
I've got very grey hair. Tom, is there any exercise that is too much or not good for the heart?
Yeah, I would say the really extreme forms of exercise, we do know that there's a J-shaped curve, and what we mean by that is if we do no exercise, the risk is high, and as we do exercise, the risk of events comes down. But the J shape means if we continue to really go for really extreme, then we do see an increased incidence of things like AF, which is an irregular rhythm. And of course, we know that, really intense exercise and marathons would be one example where we do see a higher incidence of heart attacks. Does it mean that we shouldn't do it? Well, I think it's a personal decision. I think the absolute risk is quite low. And I think maybe those really extreme Ironman type competitions, probably, if you're doing an ultra marathon lasting for 3 days, probably there's a small risk associated with that. But for most of these people, and I've got friends that are into that, and whilst I like health and fitness, the extreme stuff probably not for me. But it's part of what makes them them. So I'm kind of relaxed that people can make their own mind up. But yeah, I would say that too much exercise in that really strenuous way is probably not a good thing. And also the other side of that is, really intense bodybuilding and things like that is probably associated with its own potential risks. And
I have a couple of male patients who are a bit naughty and seem to take some supplements and things,
Yeah.
let's just say, for bodybuilding.
Yeah.
And a couple of them they have horrendously high blood pressure, and I just
Yeah.
really worry that they're a heart attack waiting to happen.
Yeah.
Do you see sort of these bodybuilding types presenting with
All the time. Yeah.
and is that related to the steroids and things that they're taking, or
I think it definitely is a risk factor for things like that you talk about. High blood pressure, we're going to have more sticky blood because the blood count goes higher. So we're talking about, obviously, injectable testosterone is easy to identify, but there's peptides and there's supplements, and they probably all have some form of exogenous testosterone. And I can understand, it's part of a lot of these men's lives, and it's enjoyable. It makes them who they are. But I can think of quite a couple of patients I've seen in the last few years that have had sizable MIs, and one of them is very lucky to be alive, had this huge hole in his heart, presented really late, and I think the biggest thing for him getting over this heart attack was just readjusting to life. It's like, well, training was just everything for this guy. And so I kind of empathize and try and kind of personalize treatment. But ultimately, the patient has to make their own mind up. It's not our job to tell people what to do. It's our job to guide them, and then they would make their own decision at the end of the day.
what about cardiologists who take a much more, like, there's some famous cardiologists based in the US who have kind of really I suppose spoken out about using diet much more aggressively to reduce the need for stenting
Yeah.
and things like that. I don't know whether you've watched any of the documentaries or read any of the books like The Forks Over Knives and things like that, which really talk about staying away from sort of animal-based foods, and that you can reverse coronary artery disease by changing your diet to a mainly plant-based diet.
Yeah.
I just wonder what your take was on that.
I think that we can do better with diet. And I think that we need more data for these types of diets. And we're talking about really rigorously conducted scientific studies where people have a very strict diet. They're randomly allocated to this diet or that diet, and we assess clinical outcomes. But until we have that data, I think the evidence for dietary intervention changing outcome is quite weak. And my approach is really, I try to listen to what the patient is telling me in terms of what they're trying to achieve. And ultimately, if that's the way that they want to go down, I would respect that. That's their decision, and I'll sleep easy. Ultimately, it's not for me to tell them. But I think that the key thing is, family history and previous events. If you've got a strong family history of heart disease, or you've had a previous heart attack, in my mind, diet alone is not sufficient. You may be lucky, right? But statistically, if I'm treating lots of patients, that we all are, that we're going to be doing them a disservice unless we're actually getting them onto the therapy that we know is proven to reduce the risk of heart attack. For an individual, they might get lucky, and that would be good. We want to prevent troubles, but ultimately, diet alone is insufficient to control risk factors for patients that are at very high risk. That's an important message.
And in terms of genetic testing, all these families that do have a very strong family history. So as you say, someone who has a mum and dad who had a heart attack in their 80s, that's not really a family history, but someone who's maybe had a parent who dropped dead at 42 with a heart attack is probably. Have we got any closer to finding the genes, or, do we know?
Short answer is no, but it's definitely important. So I guess I would split those patients up into familial high cholesterol, which is a detectable common abnormality I wouldn't necessarily think you need a genetic test for, but we can do a clinical score. And if you've got an LDL, which is the bad cholesterol of kind of 6 or 7, then chances are this is genetic. But for most family histories, we don't see that. So for that group of patients, we would think about lipoprotein little a, which is not so much inherited, but it's a marker of risk. So that's one thing. But in terms of doing the detailed panel of genetic tests for patients that don't have familial high cholesterol, we're not there yet. But there can be a molecular autopsy for people that have sudden cardiac death. Some of the time that relates to conditions outside of the heart arteries. And I think Sydney has been leading the way with that, at the team at RPA, Belinda Gray and others there at Royal Prince Alfred Hospital. So I think watch this space, but we're not there yet.
I've had a couple of patients recently present asking to have lipoprotein A checked.
Yeah.
Can you just finish by telling us a little bit about what that blood test is and who it may be appropriate for?
So think of it as an ultra low density bad cholesterol. That's an independent risk factor for blocked artery heart disease, heart attack, and stroke. It might be useful to in the future as the evidence as the government pay for injectable treatments for cholesterol, because we know that they're perhaps better to treat patients with an elevated lipoprotein little a. But at this stage, I guess it's just one marker of patients' future risk, I would say that it would be a discussion that they should have with their GP, especially if they're not keen to maybe take regular prescribed therapy. It might help to advance that discussion.
Okay, amazing. Tom, you have been so generous. I've learned so much. I would like to ask you one final question, which is about you, really, which is, if you could tell your 20-something self something, what would you tell 20-year-old Tom?
Thank you so much for having us. I've enjoyed being here. And what would I tell to 20-year-old Tom? Well, I think I would tell him, try to be kind to myself. I think I've always been really someone that gets fulfillment through getting through life, getting tasks done. That for me is really gives me a sense of purpose and value. But I would try and tell myself to try and enjoy the process a little bit more. And that's been particularly relevant, to being a dad, where you don't always, achieve goals with your kids. Sometimes it's just surviving the day, but enjoying the process and being kind, that would be it.
Yeah, amazing. Well, I agree with that. My oldest son turned 24 at the weekend, and
Congratulations.
I just couldn't believe it. And I looked back and remembered that. I remember feeling sad when he turned 5, because that sounded old and he wasn't a toddler anymore. And now I'm like, what? So I think you're absolutely right. Just trying to enjoy the process and not letting life fly by.
Yeah.
I don't know about you. Do you feel like someone's pressed fast forward and life seems to be speeding up.
Definitely now, yeah.
Thank you so much.
Thank you for having me.
This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.